Hi everyone, welcome to today's TIRADS workshop. We're going to go over some of the features of TIRADS and then we're going to try to work through a number of nodules to apply these characteristics and get used to the lexicon. But before I start, I wanted to give a big shout out to the original ACR TIRADS committee. I think they've done a phenomenal job here creating a new reporting system that can help add value to our radiology reports. The ACR website has some excellent online webinars to talk you through this reporting system and its lexicon. I highly recommend them. They are much more detailed and comprehensive than my short talk will be. There's also some PDFs with sample images of the appearances. A lot of those images will appear in my lecture today. As we can imagine, just creating a reporting system is no small feat. And I love the fact that they supplemented it with excellent webinars and helpful charts to ensure that there's widespread ease of uptake. My objectives are listed above. I did have some specific items that I wanted to cover based on my experience thus far using TIRADS. Now, in my experience, TIRADS has been an excellent addition to my thyroid ultrasound reporting. It has streamlined my reports, and anecdotally, I believe there has been reduced follow-up and reduced biopsies. But this is probably related to a number of factors other than TIRADS. Regardless, I believe my reports have added value now with specific guidance to go with my descriptions. And while it is a step forward in the reporting of thyroid nodules, I do believe there are times when there's going to be some variability, both inter-observer and intra-observer variability. For instance, is it cystic interfaces, or punctate echogenic foci? Is it hypoechoic or very hypoechoic? Now, this is not news, of course. The literature has already demonstrated some variability in the TIRADS usage among radiologists. This is a case from the article listed. And this nodule was interpreted differently by 8 readers regarding the combination of composition, echogenicity, shape, and margin. All readers detected punctate echogenic foci, but one reader also described the presence of macrocalcifications, and another saw large comet tail artifacts. It was rated TIRADS 5 for 6 of the readers, which resulted in biopsy recommendation. But it was also called TIRADS 1 and 2 by the remaining 2 readers, which led to no further management. So my point here is there can be some variation between reading of these, and I encourage you to check your nodules with your colleagues, particularly if you think it's going to change patient management. Now, I'm assuming you have already been briefed on TIRADS somewhat, but it is important we take a whirlwind tour of the appearances that appear in this chart. Again, a lot of these images are taken from the ACR teaching materials on their website, and I do recommend you check out the webinars. Starting off, we will start with composition. Cystic, colloid cystic, and spongiform. Characterizing all of these is important. The bigger challenge in characterizing these includes that you are truly seeing an anechoic lesion and not a hypoechoic lesion. I believe there can be overlap depending on ultrasound technique. As well, colloid cysts are great to say on paper and in presentations, but if the comet tail is not quite apparent, one could mistake this for a hypoechoic lesion with echogenic foci. Working closely with the sonographers is key in this aspect. And finally, spongiform nodules look great on paper, but there can be overlap between them and the mixed cystic solid nodule. The definition of spongiform is that it must be composed of cystic spaces, at least 50% cystic spaces. As an example, here is a follow-up to the last slide, and this nodule contains a few cystic spaces, but it is not over 50% cystic. Therefore, it is not spongiform. This would be classified as mixed cystic solid. Distinguishing between a spongiform and a mixed cystic solid is important, because once you call it spongiform, no further characterization is necessary. Other types of composition include solid, which is a pretty straightforward category and is defined as over 95% solid. Estimating this precisely can occasionally be challenging, but if it has very minimal cystic components, then consider it solid. The next component is mixed cystic solid, and that occurs if you are over 5% cystic. Potential pitfalls and challenges would be the almost solid nodules, in which they're like, we'll say 75% solid or 80% solid. Would you consider this solid or would you consider it mixed cystic solid? I would anticipate some discrepancy between readers. if this is a mixed cystic or solid nodule. The other thing to take into account is the location of the solid component. Eccentricity is a very important characteristic to take into mind. And here are 4 examples of eccentric soft tissue in a predominantly cystic nodule. All of these patients turned out to have papillary thyroid carcinoma. These particular patients do show other concerning features like punctate echogenic foci that can be lobulated or have irregular borders. My point here is, if it's mixed cystic solid, please note if the solid component is predominantly eccentric and characterize that aspect. Beyond composition is echogenicity. Now, I've already discussed anechoic, but we can then break it into hyperechoic, isoechoic, hypoechoic, and very hypoechoic. I would point out 2 practical tips here. Don't spend a lot of time worrying or distinguishing between hyper or isoechoic, since it's not going to impact overall management. They are the same points. Not only is it important to look at thyroid tissue for echogenicity, but you must look at the overlying strap muscles. They are key for differentiating between hypo and very hypoechoic. Sometimes you may try to brighten or blur the image. You can try squinting, you can zoom out on your PACS, you can increase the gain on your ultrasound machine, or even try increasing the windowing, for want of a better word, on your PACS system. Shape is broken into 2 main categories, taller than wide and not taller than wide. Some would call this wider than tall. However, for the perfectly round nodules, I just call it not taller than wide to include the perfectly round nodules and the not taller than wide nodules. Notes on characterizing the shape include it must be in the transverse plane. You should measure the longest dimension first, then measure the longest perpendicular dimension. If the dimension that is going in the direction of the ultrasound beam is longer, then consider it taller than wide. Taller than wide is very insensitive, but a very highly specific indicator of malignancy. It indicates the nodule is growing against the grain, so to speak. There are 5 categories of margins. Margins generally are best seen along the anterior border of the nodule, which is perpendicular to the beam, although evaluating the lateral and deep margins may be necessary in some cases. So you can have smooth, which you should be able to trace out with a pencil, and it should be a smooth curve, resulting in a ball or a bean bag, if you will. You can have ill-defined, basically it's blending in with the background thyroid parenchyma. You can have irregular or lobulated. Both of these margins indicate that the soft tissue nodule is protruding into the surrounding thyroid parenchyma. Lobulated has a smoother look, and irregular has a more jagged look. Distinguishing between lobulated and jagged doesn't have an impact on scoring. They are both 2 points. The 5th type of margin is extrathyroidal extension, which is a 3-point feature. It deserves its own slide. My practical point here is that it is characterized by clear-cut invasion of the adjacent structures. This appearance is pathognomonic for malignancy and should not be recorded merely because it's bulging beyond the thyroid. So bulging doesn't equal extrathyroidal extension. The first image shows a nodule that is invading the overlying musculature. This is extrathyroidal extension. The second image is from a publication in Radiology 2018. This is a papillary carcinoma, bulging the thyroid carcinoma in a young woman. No invasion was demonstrated at surgery. No obvious invasion is really seen on the ultrasound image. Echogenic foci are the final feature to note in TIRADS. These include large comet tail artifacts, which is a kind of reverb artifact. The deeper echoes become weaker, and they are displayed as having a decreased width, resulting in triangular shape. Macrocalcs are large enough to result in posterior acoustic shadowing. If you do not have posterior acoustic shadowing, then it is not a macrocalcification by TIRADS definitions. Peripheral calcifications should occupy the periphery or margin. They may not necessarily be continuous, but they should involve a good chunk of the margin. And small comet tail artifacts and punctate echogenic foci, as seen here, are grouped together for another final category. I do want to talk a little bit about punctate echogenic foci and its use in the lexicon and terminology. Historically, the pathologic diagnosis of papillary carcinoma was correlated with something called psammoma bodies. Psammoma bodies are a specific pathologic feature of papillary thyroid carcinoma, and psammoma bodies contain microcalcifications on pathology. Therefore, it has been assumed that the bright dots we see on ultrasound correlated with psammoma bodies on path. So, traditionally, a lot of us have called these bright dots microcalcifications. However, literature has revealed that over half of these tiny bright dots do not correlate with psammomatous calcifications. The data suggests that these bright dots many times correlate with coarse calcifications, or colloid. So we use the more inclusive term of punctate echogenic foci, and that will include microcalcs from psammoma bodies, coarse calcifications, and colloid. Basically, PEF may not relate to microcalcs at all. I do wish to speak a little bit about some of the artifacts that encounter our daily lives with TIRADS, because I think it's important to acknowledge they exist. For instance, to refresh your memory, reverb artifacts arise when a beam encounters two highly reflective surfaces that are in parallel. The ultrasound beam is reflected between these interfaces back and forth multiple times, resulting in multiple echoes. Each successive echo takes longer to hit the transducer, and the echoes are interpreted as occurring at further depth away. Comet tail is a special subtype of reverb artifact caused by highly reflective interfaces that are very close together, such as one can see with colloid. The delayed echoes are much more attenuated, resulting in decreased amplitude and width. And this gives a triangle shape. Comet tail artifact can be seen with colloid, as can be seen here. Now, this is an artifact, therefore it can be altered. This can be minimized by selecting a different imaging plane or by changing the angle of the transducer. Tissue harmonic imaging will also decrease reverb artifact. I say all this to point out that because it is an artifact, it can sometimes vary, and therefore influence your interpretation. Another artifact to be aware of is speckle. Occasionally, normal thyroid tissue may contain tiny bright dots, and these should not be misinterpreted as punctate echogenic foci. This can be related to speckle artifact. Speckle is that granular texture on ultrasound and is caused by ultrasound waves interacting with microstructures in the tissue. It can be decreased with post-processing algorithms. I'm sure a lot of your ultrasound machines will have a speckle reduction feature that you can turn up or turn down or turn off. And of course, they have harmonic imaging. Both of these will impact the speckle. So my point here is, do not over-report speckles as punctate echogenic foci. It should appear discrete and appear only within the nodule, not in the adjacent thyroid tissue. Scrutinizing the suspicious tissue and adjacent parenchyma is important. If bright dots are in both, it's probably not punctate echogenic foci. The other pitfall to think about with punctate echogenic foci is not overcalling tiny cystic interfaces within the spongiform nodule. All these are this little bright posterior border that we see in tiny cysts. And they should not be mistaken as punctate echogenic foci. Of course, this can be quite challenging at times. I will point out that TIRADS are guidelines. There can be times when deviation from TIRADS is very reasonable. Ultimately, it's up to the referring physician. But if this patient has any risk factors for thyroid cancer, such as neck radiation or family history, of course, if there's worrisome appearing lymph nodes in the neck, and if the nodules have been previously biopsied, all of these kind of make TIRADS a little less valuable. It shouldn't be applied in those particular, or strictly applied in those particular instances. I will break the TIRADS report into three main components as recommended by the ACR working group. First, describing the thyroid in general terms and giving the overall number of thyroid nodules. Then, itemizing each nodule's characteristics, totaling the number of points, any change in points, and then giving the management. And then giving a summary of your recommendations at the bottom of the report. So this is the first portion of the suggested TIRAD reporting template. I will admit, at my institution, we do not follow this recommended template strictly. Basically, if we were going to take the time to mention any nodule in our report, we just go ahead and formally document it. We don't say there's a spongiform nodule not described. We'll just describe it. This may mean reporting more than 4 nodules at our institution, and it is particularly true for the patients that are followed by our ENT or endocrinology colleagues. The second portion of the reporting template in which we document each characteristic for each nodule. And this process goes by very, very fast. I think it is very quick to catch on once you get the hang of it. In our institution, our reporting template has drop-down lists for each option with the points listed next to it, making it very easy to total it up at the end. This is the third portion of the TIRADS reporting template. ACR TIRADS suggests that a significant change in size occurs when there is either a 50% increase in volume, or there is a minimum increase of 20% in 2 dimensions and a minimal increase of 2 millimeters. There is no specification over what time interval this change must occur. I personally record the dimensions from the previous exam. Some may consider this to be extra work, but I prefer it. I like to ensure that the measurement technique is stable in both exams. I will also give the size dimensions from the earliest or more remote exams to really document the stability over time. That's something I go to the effort to really state that this nodule has been stable for 5 years or 10 years. I do recommend creating a reporting template that combines the TIRADS recommendations into one neat little package. This ensures that you have a recommendation for each nodule in the body of the report. Then in your impression, you can summarize the results as need be. Here is a potential example in a patient who would have 2 thyroid nodules. So I would take nodule 1, I would give dimensions. We're presuming that there's no previous for comparison in this instance. We give the location, and then we go through each of the characteristics. And within my drop-down menu in my reporting system, I will pick the appropriate characteristic. The points are already included with it, and then at the end of it, I will add it up and fill it in as 2. And with the 2 points, I can go to my next drop-down menu. And with 2 points, all of this will automatically populate for nodule 1. Again, for nodule 2, give the size dimensions, location, characteristics. I will add this up in my head, and I will click the 4 points. And then I will have another drop-down menu where I would click 4 points, and it will automatically populate based on the size. Then finally, for my summary, 2 nodules are present. No follow-up is recommended for nodule 1. FNA is recommended for nodule 2. I personally think it's very important to have a summary showing all your nodules and really drawing attention to the management for them. The description can occur in the body of the report, as it always should. The management should definitely occur in the impression. So if there's no follow-up necessary, that's great. And if there's FNA, I would definitely bring attention to that. This concludes the intro part, covering all the TIRADS characteristics. These are some of my references. Now we're going to proceed with going through some of the nodules on a case-by-case basis.